Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect with the profession. I'm Nicole.
And I'm Leo. In today's episode, our guest is Ethel Frese. She is a professor emeritus at St. Louis University's PT program, a Catherine Worthingham Fellow of APTA, and has decades of experience to share.
On today's episode, we discuss how she got into PT and acute care, her influence on students, and the importance of lifelong learning. Hope you enjoy the show.
All right, welcome to today's episode of Acute Conversations. On today's episode, we've got Ethel Frese as our guest, Professor Emeritus from SLU University. And Ethel, welcome. Thank you for being here. Let me just preface this first is that, Nicole, thank you so much for being my co-host today. And you're actually the one that helped facilitate this whole situation. So, Ethel, can you talk about how you got invited as a guest for our podcast?
Well, I met Nicole doing a clinical residency site visit, and we got to talking. And the next thing I know, she's asking me if I would do this podcast. So, and I couldn't say no to her.
There we go.
So that's how I got involved. It all goes back to being a clinical residency site team member.
Yeah, and boy, did we get to talking. You shared so many great stories, and I really wanted you to be able to tell some of your stories here for our Acute Conversations podcast and get that out to listening ears.
Well, you may have to prompt me, Nicole, because I don't remember all the stories I told you.
Well, that's fine. That's fine. You've probably forgotten most, more stories than most of us have remembered in terms of acute care, in terms of all your experience. So why don't we take a step back and just kind of talk about how you even were exposed to the field of physical therapy, and then how that also translated into working in a hospital setting, working into the acute care setting.
Well, back when I was young, physical therapy was not very well known. It's much more known now than it was back in the 70s, or when I was in high school in the 60s. And so, but I come from a medical family. My father was a physician, my mother was a nurse, and both my brothers are physicians, and my older sister's a med tech. So my younger sister's a nurse. I have one sister who's in, video production. So she's the only non-medical person. So I came in, from a very medical family. But when I was in grade school, when we got to taking science, I always was excited when we got to the anatomy, physiology chapters in the book. Mm-hmm. So I knew even as a young kid, that was something I loved. So I knew I wanted to do something in the healthcare field. So anyway, one summer I volunteered as a candy striper at the hospital in Chattanooga, Tennessee, where I grew up. And I thought, well, maybe I want to be a nurse. I'll volunteer on the nursing floor. And I know some of you young people might not even know what a candy striper is, but, I run errands or transport patients or whatever. So anyway, I thought, I'm not sure nursing's for me. So one day I decided I'd volunteer in physical therapy. And so I would, transport patients or, put hot packs together or get the ultrasound machine set up or whatever. And I thought, and then I got to watch a lot of therapy. And there was a young physical therapist. I'm guessing, looking back on it now, she was probably in her mid to late 20s. She had 2 kids. I ended up babysitting for her a few times over the summer. And she also, we talked a lot about physical therapy. And she gave, she really encouraged me along and talked a lot about what kind of work it is. And so it just cemented. I thought, this is what I want to do. And I remember my mother picking me up from the hospital at the end of the day. And I got in the car. I said, Mom, I know exactly what I want to be when I grow up. Now I'm 15, so I'm not fully grown yet. Anyway.
Wow.
She said, well, what is that? I said, I want to be a physical therapist. And I'm sure she probably thought, yeah, sure. But I never looked back, never changed my mind. Picked out a university that had a good PT program, which was Washington University here in St. Louis, which is how I ended up in St. Louis. And never regretted it. I loved it from the very beginning.
That's amazing that, sometimes I have kids that are in high school that are having to do service hours or volunteering. And even in my own life, just kind of like those opportunities where, you volunteer and you're just like, oh, maybe that's what I want to do. And that's such a impactful experience. And the fact that physical therapy, that what you had witnessed was in the hospital setting, which kind of led you down this path. And so you get into PT school, you already knew then that you wanted to go into the hospital setting for physical therapy.
Oh yeah, and the other advantage that I had was there's another hospital in Chattanooga where I was born. Actually, it had just opened right before I was born. Well, anyway, there was one physical therapist at this hospital, and she had an aide that worked with her, obviously, and getting transport and all that. Anyway, the aide would take 3 weeks of vacation. So this woman, when she was good friends of my parents, when she found out I wanted to be a physical therapist, she hired me every summer to work with her while her aide was on vacation. So I learned to do hot packs. I learned to do ultrasound. I learned how to transport patients in the old wooden wheelchairs that most of you've never seen. They didn't have brakes. I learned how to use my foot as the brake. But again, I did. So when I got to PT school, I already knew a lot of the information that we were getting. So it put me a little ahead of some of my classmates, only because I'd done it, in high school and college before I got into PT school. Because back then PT was, 2-year undergrad, then junior and senior year was PT school. So, and I had been doing it since I was in high school. So I already knew quite a bit, but I also had a lot more to learn, of course.
Right.
But, again, so I had time as a volunteer, as a candy striper, but also, a PT assistant, I guess you could say, sort of, not like we have now. An aide is probably better. But the other thing that I did, I was a certified nursing assistant as well.
Oh, okay.
And so I learned how to catheterize patients. I also had to get a patient prepared to go to the morgue. She was like 28 when she died. And I had just come on duty. So here I was like 17 or 18, and I had to get this body prepared for the morgue. That was a challenge. Yeah. So I got a broad experience and learned how to cope with families and issues that came along. So I grew up in a hurry, but again, it was a very valuable experience, all those opportunities that I had.
Yeah. Do you remember any experiences from being at WashU? Any other students that you were in the cohort with?
Well, yeah, because back then they only took a class of 20.
Wow.
Which a lot of you young people say, what? And so two of the students dropped out in the first semester. And so we only had 18. So we all got along really well. The other thing that was interesting is, especially back then, physical therapy was primarily a female profession. That's not the case so much now. But about half my class were males.
Wow.
And so, but, we helped each other out, and, it was a really cohesive group because there were only 18 of us. And, I can remember when we were doing massage class, and here I am lying on the table, and there was a guy right next to me. We were both getting a massage. And I said, I can't believe I'm just getting to know all these people. I'm already half naked. So you lose your modesty pretty quickly in PT school.
Oh, I think that still stands.
Oh, I'm sure. I know it does.
I think in PT school, you still gotta just be hands-on, right? That is essentially what we do. Yeah. So after you finished school, is that when you started working right into acute care at that point?
Yes, my very first job as a new grad was at a county hospital, which sadly no longer exists, but it was a perfect place for a new grad because it had an outpatient department. It was all one big department, but we had outpatient, acute inpatient care, and long-term rehab. And so, one of my all-time favorite patients was one who had a head injury from a motor vehicle accident, and I had him for 9 months. He was at the rehab facility for 9 months. So he and I got to be, good buddies. But I also started a cardiac rehab program as a new grad, and my boss gave me time to do that. So, and there was a physician at the hospital who was also on faculty at St. Louis University Medical School, who, fostered me along and approved of it and loved it. And so I learned, as a new graduate, I had a very broad experience, different kinds of patients. So, it wasn't just acute care, but I always have, was very attracted to acute care.
Yeah. Do you think that there's some, benefit to starting out in a place where you were able to go across different settings or different levels of care, and you were already starting to go into the cardiopulmonary world at that point, but still had a broad experience with outpatient and inpatient and acute care.
I also did home health for like 20
and
years.
home health.
Wow.
Yeah.
Yeah.
So, what do you think about that idea of acute care therapists rotating between diagnosis or rotating between floors or units?
Yeah, that's, I know for me, I loved rotating and doing neuro and cardiac patients and pulmonary patients and ICU. And of course, back when I was young, patients would be in the hospital 2 or 3 weeks. Now they're in and out in just a few days. But so for me personally, I'm glad that I had the opportunity to see diversity among patient diagnoses. It also was very valuable, and I think it's very valuable for acute care, because a lot of your patients in acute care might be coming in for, let's just say, orthopedic surgery or a neurological event, but they also have a cardiac or pulmonary history.
Yes.
So, being able to read a patient chart and see, oh, they've got a history of a stroke, or they, have a history of bypass surgery, or, lung transplant or whatever. So for me, I didn't want to narrow down very, very early. I really loved but I know for some therapists, they really want to just go to a neuro floor or just the orthopedic floor. So, but I also caution therapists that once I went over to the academic side, I felt strongly, in order to teach therapeutic exercise and cardiopulmonary and exercise physiology, which were my 3 major courses, I needed to stay active in the clinic.
Yes.
That was extremely important to me. And so, because I think if you're going to teach a clinical science, you need to be active in that clinical science. But I also would say, for me, having a broad background across multiple diagnoses really helped me, I think, be a better physical therapist, but also a better teacher.
Didn't you call that going over to the dark side?
Who, me?
Leo's on the dark side, right? You're on the dark side, Leo? Is that right?
I am on the dark side.
I guess I have to say, I used to joke that when I went into academia and still stayed at the hospital, of course, that yes, I was crossing over to the dark side. But I love teaching. I wouldn't trade what I've done. I love treating patients. I love to, my therapy job, but I also really love teaching students. It's one of my favorite things I've ever done.
So I wanted to ask you about that, Ethel. So as you were, you graduate, you're working in an acute care setting, working in the hospital. If anything, I should ask you where you have not worked. What setting have you not worked in? Because you all these different ones. But when did that transition? Can you talk about how you transitioned from working, and then how did that opportunity come about to work in academia?
Well, I actually started working and doing a little academia as a new graduate, actually, because, as I said, I graduated from Washington University, and mobilization had not really come into this country yet. Stanley Paris came the fall after I graduated and taught a 2-week course, and I got to take it. And so I guess word got out that I'd taken this course on mobilization from Stanley Paris. So Washington University, they sent out a survey, and they wanted to know what we graduates thought should have been in the curriculum that wasn't. And I said mobilization was important to include, but also renal. We didn't have much renal then either. And so I get a phone call. Well, would you be willing to teach those things? Well, oh, sure, I'm an expert now. I mean, I had done quite a bit of mobilization, but I said, I will do peripheral. I will not do spinal. Yeah, I didn't feel I was good enough to teach that. So interestingly enough, I taught renal and then cardiopulmonary. But then when I was interested in cardiopulmonary, and I said I wrote a cardiac rehab program as a new graduate, word got out because there really wasn't much in the Midwest in terms of cardiac and pulmonary physical therapy. So when word got out that I, was doing that and starting programs, because I also started a cardiac rehab program and a pulmonary rehab program at St. Louis U Hospital. So then I got a phone call from a friend of mine who was on faculty, and she said, would you be willing to come teach cardiopulmonary at SLU? And I said, oh, sure. Well, of course. I thought, I'm not sure how to teach, but I'll give it a shot. But I also, interestingly enough, started teaching both cardiac and pulmonary at Washington University. So word got out that I was, doing cardiac and pulmonary rehab, and could I teach it? Because there really weren't people in the St. Louis area who could. I was pretty much it. So I said, sure. And I didn't have much guidance on how to put together a lecture. I mean, obviously I attended lectures, but so I learned along the way, and, got good reviews from students. And so I guess I wasn't awful.
No. Yeah. You are a legacy in the world around here, and in terms of the lives that you've impacted, in our community. I mean, do you have any clue how many people you've taught at this point?
Well, as I mentioned before we started recording, my son asked me that not long ago, and he said, "Mom, do you have any idea how many therapists or students you've taught or influenced?" I said, "Honey, I have no clue," because at that point I've been 46 years or some such thing, and I said, and I've done about 70 continuing education courses. So I said a lot, but I couldn't even begin to tell you how many, and hopefully it was a good influence.
Okay. So, you mentioned that you were working at St. Louis University Hospital. I think you were the chief, right? And
Yes.
Teaching at the university physical therapy programs, both at St. Louis University and WashU.
Correct. And then I don't remember what year, but I think it was in like 2001, maybe 2002, something like that. I went to a national meeting in Florida. We had to get up and introduce ourselves. The chair of the PT department. I met a man who was the chair of the physical therapy program in Chattanooga, Tennessee. And when I introduced myself, so I, teach cardiopulmonary. Well, he came up to me, he said, "We need somebody to teach cardiopulmonary at the program. Would you be interested in doing it?" And I said, "I'd love to do it, but I can't move to Chattanooga." At that point I had 4 kids, and, I've been in St. Louis forever, but I said, "I'd love to." So I started teaching at the University of Tennessee in Chattanooga. And then I got a phone call from the chair at the University of Tennessee in Memphis. So at one point I was teaching at 4 different universities. Yeah, no, it was busy, but it worked out. I was able to work it out and, torture that many more students, but it was fun meeting different people. And of course Tennessee was my home state. And it was kind of fun going back to Chattanooga. And I also sort of mentored along someone to replace me at both universities. I think this past fall was the first time I didn't teach in Memphis. And I also mentored along the therapist who took my place in Chattanooga, which was great to see them, and she's always told students and people that I've worked with that one of the best gifts to me as a teacher is to have someone you've taught do better than the teacher. And I have a lot of really good gifts that way. Lots of people I've seen have gone way beyond their teacher, and that's huge to me.
Absolutely. I was about to ask you, in terms of your teaching career, are there any good stories you have of students that were just maybe coming into PT school adamant that, hey, I'm going to go into sports, I'm going to go into ortho, or didn't want to have anything to do with acute care, and eventually?
Oh, absolutely. I've had several students who swore up and down they were going to go into orthopedics. And then, I ran into them in a meeting or something, and they'd say, "Well, Ethel, you're not going to believe this one, but I work in acute care and I love it."
Wow.
Not just one, several have said, "I found orthopedics boring." I went, "Well, okay." You won't find acute care boring. At least no place I've ever worked with acute care did I find boring. So, it's nice to see, as I have mentioned, acute care was somewhat popular when I was a new grad. And then it kind of went out of the scenery, so to speak. People didn't think that it was that good, but then now it's been fun for me to see it come back. Yeah. And more therapists are saying, "Oh, I think I like acute care." And again, the story of the new graduate who was at CSM, and I was at a poster, and it was about acute care, and he came up to me and he said, "Well, the smart people don't really go into acute care." Now, that was not the right thing to say to me.
No.
Know your audience.
Clearly, he wasn't very smart.
Know your audience.
I would say he was young and dumb.
Naive, yep.
But I would have never said that to anyone, but especially, obviously, an older professor. No way would you say that. And so I said, "Well, I bet you don't know anything about lab values, ECG, blood pressure," because for a long time, orthopedic people didn't even think about taking vital signs.
Yeah.
I think that's gotten better.
Mm-hmm.
But
Mm-hmm.
for a long time, it was not even on their radar.
Right.
And I thought, well, so I'm guessing there's a lot you don't know. And so I would suggest that you learn something more rather than insulting another physical therapist. That's not a good career move for you.
Right.
The other thing that I found remarkable about your career, some of the stories you got to tell me on our site visit together about interacting with the academic model, with the residents, with the other learners that were in the hospitals that you were working in. You have any particular memories around that stand out to you?
You want me to tell you the story about the crutch?
That's
my favorite. My favorite resident story.
Yep.
Anyway, there was a resident. He had med students lined up behind him, so he couldn't see their faces. He was looking at me because he'd come down just to check on things, and he had written an order to do crutch gait, non-weight bearing, bilaterally. So I thought, okay, I can't wait to see how this is going to go. So I went up to him and I said, Dr. So-and-so, I'm really sorry, but I don't know how to teach a patient to do crutch gait, non-weight bearing bilaterally. But if you'll show me, I'd be more than happy to teach the patient. Meanwhile, the med students were cracking up, but he was too dumb to realize how stupid he was. So I started to hand him the crutches, and he looked at me and went, "Oh, just do whatever you want to do." Okay, doctor, I will.
Wow.
Obviously, I remember that because I was my first job. I was a fairly new graduate, and I just thought, "Oh, wow, remind me never to go to you."
Right.
Yeah, I don't know that there's a single acute care therapist that's listening to this that can't think of a similar story.
Right, and relate to that situation.
Yeah.
And this isn't a funny story, but one of the things that I've seen change over the years, which I love, and that is the interaction of doctors and residents and med students when you happen to be on the nurse's station, as an example, maybe typing a note or whatever, how much they have changed in terms of respecting the level of knowledge of physical therapists. That did not used to be the case so much. It was like, we're here and you're down there somewhere. We know a lot more than you do. And I think that's been a big change, I think, where the doctors working in the hospital setting really respect what physical therapy brings to the table and the level of knowledge that we have and the level of care we provide. I've seen that as a big change over the years.
That's great to hear, and I can attest to that as well. I feel that when our new grads that are coming out that are prepared and armed to be able to discuss literature, to discuss some of these topics, and again, like you said, we are, in terms of our wheelhouse of what we are specialized in terms of human movement, really we're the experts in that field. And so there's residents and doctors that come to consult us and get our opinion and how much value we bring to the table in terms of those conversations. And so I wanted to touch on this too, that in terms of the literature and the science that's out there, outside of teaching, outside of being a clinician, you've also published a number of scientific articles too. And I'm just wondering how are you able to fit all that in as well in terms of getting involved in research?
Well, it was strongly encouraged, in the academic world. I would never say I was a big researcher. I think the PT faculty that I know and knew who did mostly research, they didn't do much clinical work. But because it's tough to do clinical work and a lot of research and teach and prepare lectures, by the way. So, but since I was teaching mostly clinical type coursework, therapeutic exercise and exercise physiology and cardiovascular pulmonary, I felt like staying active in the clinic was critical. So I worked a lot of weekends to do that, but also research was required. Now, would I say I'm a mega researcher? Of course not. But I had some good team players to work with who are also cardiovascular pulmonary specialists. And, we worked together to, put out some, I think pretty good studies. I'm not going to say I'm going to compete with somebody who has NIH funding, but so research was not my strong suit, but I liked coming up with the questions and, trying to come up with the answer. But if you were to ask me, what's your favorite thing to do when you look at teaching and research and clinical work, research wouldn't come in as high as clinical work and teaching. Because as I said, I love teaching. I love the students. And the other thing that I have found that in doing, and I think Nicole's going to agree with what I'm getting ready to say, that one of the most common threads that I have heard, because I usually ask this question when I'm doing a clinical site visit for a residency, I'll ask the faculty mentors, why do they really like being mentors? And one of the most common answers, if not the most common answer I get, is they enjoy learning from the resident, but the resident also has helped them become better therapists. And I knew as a new grad, I had a couple of students, and I'd only been out a year, and all of a sudden I've got, 2 PT students that I was supposed to be their CI. But I also learned that they had some things in school that I didn't, or didn't have as much of. And so I discovered pretty quickly that, teaching, especially students who are doing their not residencies, but certainly for residents, that didn't exist back in the day. But, students doing their clinical assignments to get there, to graduate, I learned from them too. And sometimes they obviously had different professors than sometimes from what I'd had, different perspective. So, I figured out pretty quickly to keep an open mind and listen and learn from other people. That you might have more experience, but that doesn't mean what experiences they've had or learning isn't as good. In fact, as I said, they have sometimes had seen things I hadn't, or a different perspective from another professor they had. So, to me, that's the real value of teamwork, and learning from other people. And, I think a big mistake is if you think you already know everything, that's a death knell for your growth, in my opinion.
I think another mistake along those same lines is holding off on taking students until you know everything. I think we see that quite a bit.
Well, then you'll never take students.
Exactly. It's a learning experience. It's a partnership. Absolutely. I love that you called it a team, and the more students we can bring into the hospital, into the acute care, the better for the longevity of our profession.
I absolutely agree. And students ask frequently challenging questions.
They do.
And I remember one CI I had at an acute care hospital, she would pretty much never answer our question. Her one answer was, go look it up. Well, I'm all for looking things up. However, you get the sense, at least I began to think, she didn't know any of the answers. Because she never answered questions. So I gave up asking and, asked another person on the staff who I got to be friends with. I would ask her instead of the CI. Because I thought, why am I wasting and I was all for looking things up, don't get me wrong. But if someone never answers a question for you, you begin to wonder if they don't know the answer for anything. But again, that's one of the things I loved about having students, but also in the clinic having students. They do challenge you and make you think. And sometimes you have to go back and say, it's easy to get into the habit of doing something a certain way.
Right.
When someone asks you, well, why are you doing it that way? It makes you stop and think, well, this is the reason I do it. You don't it's in your brain, but you don't necessarily think it through because you've already been doing it so long, So I think that's a value of teaching. You have to go back and think, now, why do I do it that way?
It's a great segue. You talked about at the beginning of our recording today that your career started out as a candy striper. And if I remember right from our conversations on the site visit, it kind of has come full circle in at least one or two ways. And you got to go back to that same hospital. Is that right?
As a matter of fact, oh gosh, I don't know, a month, 6 weeks ago, I lose track. It was in June. June. So, almost 2 months ago now. Anyway, I did go back to that hospital. It was fun going back in because I hadn't been in that hospital in a long time. So it was fun for me to go back as, a clinical residency site visitor, to go back to where it all started for me. And what was fun is one of the people at that hospital, my dad was an OBGYN, and he was her physician and he delivered her.
Wow.
Yeah. So, and she had been, to one of my courses. So it was kind of fun, it's a small world actually in many ways.
Mm-hmm.
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 Ethel, I wanted to ask, because you had already touched on this earlier, just about the difference compared to when you first started in your early career compared to now, some of the changes that you've seen in acute care, like the amount of respect in a way, or in terms of acknowledgement of what we do, right? And when other doctors and residents are now consulting us, even just that word consult versus order, or
Exactly.
the things that have changed in terms of length of stay. So I wanted to kind of get your perspective for somebody that's been in the game for this long. What are some of the other things that you've seen change for the acute care setting and for acute care therapists?
Well, I think that the acute care education has gotten better.
Mm-hmm.
And, of course, I didn't get much in the way of ECG when I was a student. But when I was working on my master's degree, I took an ECG course. I was also, did a lot of self-teaching of ECG. But what I found kind of fun was my students get more on, the students that I taught got more on ECG than most nurses got in school. My sister got almost nil. She worked in ICU, but didn't get much in the way of ECG in school. I can't speak for that now in terms of nurses, but I know this has probably been a year or two ago, not longer than that, probably more like 3 or 4. Anyway, I was sitting at the nurses station at the hospital and, at the computer doing a note, and there were several nurses that were trying to figure out what the ECG abnormal rhythm was. And I was hesitant to volunteer whether, if they wanted me to answer it for them or, give my input. But I said, well, I'm happy to help you all if you want me to. I teach ECG. It was atrial bigeminy. And so I said, I think I can answer it for you. And they took it well. I said, I teach this, so I'm happy to help. And they said, well, yeah, what is that? I said, well, it was atrial bigeminy. And so they didn't seem bothered that there was a physical therapist who knew something in what some used to think of as just nursing expertise. Mm-hmm. But, I'm a very strong advocate that if you're going to work in acute care, you need to know ECG.
Mm-hmm. Yeah. Mm-hmm.
Now, are you going to know it as well as a doctor who interprets ECGs? Of course not. But especially the, more common abnormal rhythms, that's it, because it might mean you shouldn't be treating the patient. Mm-hmm. I remember one of the times I was in the cardiac care unit and the patient had bypass surgery and he had not been out of bed before. And so I, did vital signs. He was supine. I got him up to sitting and he was in normal sinus rhythm and supine. I got him to sitting and he went into atrial bigeminy. Mm-hmm. So I said, well, I think I'm going to have you lie right back down again. The cardiac surgeon walked in the room and I said, Dr. So-and-so, I just want you to know that he was in normal sinus rhythm. He was still in atrial bigeminy when the doctor came in. And even though I was getting him lying down. Anyway, I said, he was in normal sinus rhythm. He went into atrial bigeminy as soon as I sat him up. So I'm, that's why I'm in the process of lying him right back down again. So the doctor looked, he said, yep, that's atrial bigeminy. All right. So I'm like, yeah, I got it right. Right. But anyway, I think he respected the fact that I knew exactly what it was and knew what to do about it. And so then he asked his colleague, he said, now what do you think we should do for treatment? They were thinking of meds and that kind of thing. Wow. But again, I think that we have to earn respect. Mm-hmm. I know some graduates think the initials behind their name mean a lot. Mm-hmm. Not in the world I was used to. When I would go into the DCU on the weekends, the nurses, because they usually had pretty much the same crew every weekend. Yeah. So they would, if I was working, they'd be, oh, Ethel's here. But they couldn't have told you how many initials I had behind my name. They didn't care. No. They just trusted that I knew what I was doing and they respected what I brought to the table. To me, that's so important for new graduates and students to learn. You earn respect by how you treat people. Yeah. You're open to learning. Yes. And you don't know everything. And so the initials behind your name, patients don't care what's behind your name. And I never introduced myself as Dr. Ethel Frese. or Dr. Frese. I always would introduce myself to patients and their families. I said, hi, my name is Ethel. I'm your physical therapist today. Let's be real. A lot of patients, if you introduce yourself as Dr. So-and-so, they're going to think you're a medical doctor. And I wasn't even going to go down that road. I said, I'm your physical therapist, because again, patients don't care about the initials behind your name. They just want to be sure or feel like you know what you're doing. And so, I don't want to insult anyone's initials, not by any stretch. But again, they don't mean much to other, especially patients. Patients, they really are more interested in, do you know what you're doing? And can you interact and talk with them and communicate and listen? It's a huge part of I think, of how we interact with patients is listening to them and their families. What is it they want to achieve? And, what's the most important thing for them to achieve? And I'll do my best to help you achieve that.
Those are some great pearls of wisdom there, Ethel. And I agree that, we have to really remember that our patients in acute care are potentially having the worst day of their lives, right?
Well, absolutely.
And you're right that they're not concerned with the credentials of somebody who's walking in the room. They just want to feel better. And agree that the biggest part that we can play in acute care physical therapy is really staying abreast of what's new, what's out there, what are we doing, how are we practicing, are we practicing reading all the changes that a patient has as we give them our interventions, and are we trying everything we possibly can. I know you have taught, for many years. You taught in the classroom, you taught as a mentor, and you taught lots of CEU classes. Any CEUs that you are like, oh yeah, this was my favorite topic to teach on to practicing clinicians?
Oh gosh, probably. Of course, I love exercise physiology because that's, to me, a basis for cardiac and pulmonary. But in terms of cardiac and pulmonary, because that's my favorite. I mean, I love teaching exercise physiology. Don't get me wrong. I love therapeutic exercise, but cardiac was probably my favorite topic. I love the heart, and I found it fascinating. And but I also love pulmonary because, to me, it's fascinating how much they work together.
Yes.
Obviously, right heart failure versus left heart failure, and to me, the whole physiology just is fascinating to me. It makes perfect sense, which is, I guess, why I ended up becoming a CCS, because it was, I discovered as a new graduate, I loved it. And still do, it was great to teach it. But again, if someone doesn't really like physiology, then cardiopulmonary is probably not for them.
It's going to be tough. You're going to have a rough one if you don't like this.
Exactly.
Nicole, you had mentioned about staying abreast in terms of the literature, and Ethel, you had also mentioned about how our education has gotten so much better in terms of both the education that we provide in PT programs, but even the continuing education, where we've got rock stars like Ethel teaching continuing ed courses. Nicole, I know that you are helping out with Bridge the Gap through APTA Acute Care. Can you talk maybe a quick plug for our continuing education that we're putting in through APTA Acute Care?
Yeah, sure. So the acute care section is hosting Bridge the Gap conference again in the spring of 2026, May 1st through the 3rd to be exact. And we did this not this last spring, but the spring before. And Leo and I got to go and participate in the committee planning at that time. So again, Northwestern University is kind enough to host this conference, which makes it, more intimate. It's in the Chicago region, so pretty easy to get to from both coasts and from the middle of our country here. And, like what Ethel was talking about, how important it is to stay in the loop of what's going on across different settings. We want to look at rural hospitals, mid-sized hospitals, academic or city-based hospitals, and critical access facilities. But anything acute care is welcome to come. We're seeking poster and forum presentations for the conference, and those will be due in early 2026. So start preparing your abstracts, and hopefully we'll see you there in May.
Yeah, come to Chicago, my city. And then what we did, I think, last time, and actually this is how I met Nicole, is that we ended up going, we took a group, we asked some of the attendees if they wanted to go for a run. by Lakeshore Drive on the lakefront. So
Oh, that's a beautiful place to run.
Absolutely. I think we're going to start closing things up here. Ethel, one last thing before we move into our rapid responses is I just wanted to ask you, what are some of the challenges that you foresee for acute care therapists and for our profession moving forward? We've worked so hard to be able to gain the respect and educate our therapists to be able to add value in the hospital system. But what are some of the challenges that you see the next 10 years, 20 years down the line for us as a profession?
Well, I think, who knows what new kinds of technology will come along. And so I think getting therapists that are willing to stay in the profession, because, I've talked to a number who have left physical therapy after 6-7 years, which I find sad, but, I want them to be happy. So, I think keeping up with technology, I think meetings like combined section meetings, that can be challenging to afford to go to, because not all jobs provide money for people to go.
Right.
And so, but I think that it's so critical for us as professionals to stay abreast with whatever area is our area of expertise, so to speak. So to stay thinking critically, keep up with new technology, going to the learning center at APTA, they've got good things that didn't used to exist. And so it's nice that therapists now have the opportunity to keep up with the literature, because things change so quickly. And I think it is hard when you're working 8-10 hours a day, to stay abreast, to, go to continuing education courses or combined section meeting or whatever. But I think it's real important. The other thing I would encourage people to think about is, becoming CIs, taking students, but also item writers, if they are specialists, to volunteer and Nicole's down there laughing, but, to volunteer to be item writer. The sun's coming in my window here, I'm going to see if I can change where I'm sitting. Oh, sorry about that. But anyway, so I think the challenge will be, making sure that people respect what we bring to the table.
Absolutely.
And that physical therapy is a very important component of patient care. I think it's come a long way.
Yes.
And compared to when I was, young, because people didn't much know about physical therapy at all. So it's come a long, long way. And I just wanted to continue doing that. And so the more we can interact with other healthcare professionals, the nurses, doctors, med students, depending on where we work, to help them understand what we do bring to the table, and to, stand up for what we think is right. That's not always easy to do, but I think it's important to do. Does that answer your question, Nicole?
Absolutely. Yeah. Thank you for sharing your wisdom, your stories, and just reflecting back on how many people that you've touched throughout your profession, whether they're students, patients, other clinicians, other healthcare providers. Ethel, it's been a treat to have you here to be able to share your wisdom and stories.
Well, thank you for asking me. As I said, I was 15 when I decided I wanted to be a PT, and I've never looked back and have never regretted it. I've loved every minute of it. And I've been very blessed to have such a wonderful career. And, the number of really wonderful people that I've worked with, have met, students that I've taught, it's truly been a wonderful career for me. So it's time for you youngsters to take over.
Well, we're going to take over right now, because we're going to enter the last segment of our podcast, which is called Rapid Responses.
Oh, goodness. Okay.
So we're going to time you for a minute, talk about being blessed. We're going to bless you with some fantastic questions. We're going to time you for a minute. The first thing that comes to your mind, just like a rapid response in the hospital, you're just going to blurt it out. Sound like a plan?
I guess. Hopefully something will come to my brain. I have an old brain, Leo. Come on now.
It's all good. Let me set up the timer. Nicole, did you want me to start, or did you want to ask the first question?
I'm ready to ask the first question here.
All right, and let's get started and go for it.
All right, Ethel, if you had the ability to time travel, would you go to the past or to the future?
Oh gosh, that's a tough question. How far in the past are you asking? I mean, like, okay. Actually, a part of me wouldn't mind going back to, like the Middle Ages to meet my
Ooh.
ancestors, to see
Cool.
what my ancestors were like. To say, wow, you must have had great genes, you lived, because people died young back in those days. So, you know, I don't know that I want to know what the future is, to be honest. And there's a lot more behind me than forward. Well, let's be real here. So, yeah, I think, yeah, I've often thought I wouldn't mind going back and meeting my ancestors to see what they were really like. So yeah, I think that's my answer.
Here's an easy one for you. What's your most favorite color scrubs to wear in the hospital?
Well, I had to wear forest green. We didn't used to wear scrubs. For a long time, I wore lab coat. And then the hospital I was working at started having therapy wear forest green. So I liked forest green. And people said I'm sort of a fall color in terms of my complexion. One of my sisters is a spring. I'm a fall for people who, that used to be a big thing. But anyway, so yeah, I guess forest green.
Forest green?
Yeah.
All right, I got another question for you. If you could only eat one type of cuisine for the rest of your life, what would it be?
One type of I eat a lot of salad, so probably salad, because you can kind of vary salad around a little bit. So
you're so healthy.
Your heart. I don't know about that.
I got a question for you, Ethel. Name one therapist that has been influential in your career.
Oh, that's an easy one. Her name is Mary Chrisman.
Okay.
She was the therapist that I went to at the hospital when the other therapists would not answer my questions. Wow. And she's a friend even today. So she took me under her wing when I was a student, and and we talked together some. She was on faculty for a little while. So yeah, that's an easy one for me to answer.
Fantastic.
That's amazing. All right. So I think the final one, right, Leo? Because all right, Ethel. How you're an acute care therapist when
complete the sentence.
Finish that sentence.
When you can manage, I'm going to say acute illness, but ill patients who need very specialized care, and that you can manage the really sick patients and the not so sick, and you're good at vital signs and ECG and ventilators and all the machinery that you see in acute care. Yeah. So I guess that's my answer.
That's the perfect answer. Yeah.
Absolutely. Ethel, if people wanted to follow you or wanted to ask you questions, what's the best way for them to reach out to you?
Probably email for me, which I think I gave you. That's on that form that I filled out.
Absolutely. We can include that in the show notes for sure.
I don't have LinkedIn and Instagram and all. That's all for young people. That's not for the elderly. So, but
I think you get a lot of followers though. If you had one of your grandkids to open up an account for you and just follow you with the phone and just take video.
I follow Ethel Frese. That's so cool.
Absolutely.
But the problem is, Nicole, you might not be interested in where I'm leading you.
Let me decide that one.
No, it was a pleasure working with you, Nicole.
Me too. I really enjoy getting to know you, and especially getting to know you today even further. This was amazing.
Well, I'm glad I didn't disappoint you. Mm-hmm. And, and one last comment. I still think gait belts are important.
Yeah.
Good.
You hear that?
Put your gait belt on.
I can tell you, I think I would have had patients in all my career over, like 46 years. I never had a patient fall.
Wow.
Never. And I think part of it was I had strong legs, so they could sit on my legs if need be.
Yeah.
But also I had a gait belt that I could hold on to.
That's right.
I can think of several times had I not had that gait belt, I think they would have been on the floor. And then I'd had an incident report, which I never had to fill out an incident report. I was allergic to incident reports, so I didn't ever want to have to fill one out. So I'm a big fan, and I know that's probably a controversial comment on my part because I know not everybody's using gait belts these days. I happen to be one who always would. Never would I go without a gait belt. And even people who've had heart surgery, I'll put the gait belt over the cardiac pillow, so to speak.
Yeah.
And it works fine. Now, sometimes if they've got a lot of tubes, that's a challenge, but I still feel a lot safer with the gait belt. Absolutely. Are there times when you might not be able to? Yeah, if they've got several different tubes coming out, okay, I get it. But I still got pretty creative in the gate belt world. And so I just felt safer.
Yeah.
And you don't want to be in a court of law and then have to say, no, you didn't have a gate belt on. It might not go well.
Right. So students that are listening out there that get angry that we're so specific about wearing gate belts during your practical exams, from real life experience from one of the pros, use your gate belt.
Yeah, that's my personal opinion. They can disagree with it, but that's who I am. And I can tell you it's saved me more than once.
That's awesome. Well, thank you, Ethel. Thank you for everything. And again, thanks for spending time with us to be on the podcast today.
And best of luck to everyone. Take care and keep growing. You're welcome.
We would like to thank Ethel for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. This episode was hosted by Leora Guellis and Nicole Naveau. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay. For more information about APTA Acute Care, be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us next time for another engaging acute care conversation. Thank you for listening, and may our shoes and scrubs stay clean today.